Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to look at induction of labour. Let's look at induction of labour. So what is induction of labour? In the dictionary definition of induction means to bring on or bring about something. And there is a difference between induction and augmentation, and that's important to point out. This is not augmentation. Augmentation is when the labour's already started and has stalled for some reason, and you're then putting measures in place to continue that labour. Induction is where labour hasn't actually started at all. And is it a big issue? Well, the National Maternal and Perinatal Audit in 2022 for England and Wales states that a third of all singleton term pregnancies are induced, which is a phenomenal amount. And the World Health Organization state that ranges from 1.4 to 35%, depending on whether it's a developed country or an underdeveloped country, or developing country, I should say. And back in 2011, the World Health Organization raised concerns that in developed countries, back then there was already 25% of pregnancies at term that were being induced. And they highlighted induction's not risk-free. And that a lot of women found this very uncomfortable. So we haven't really learned very much since 2011. And in fact, the numbers have just increased. The most recent CQC report for this year, and at time of recording, this is September, so this is this year's, 43% of pregnancies were induced. And that's consistent with previous years. And that number has been increasing, as I said, since 2011, when it was 25%, and we're now up to a third of all singleton term pregnancies. So, that is a phenomenal amount. Our maternity stats for this year are still, echoing what all the other figures are saying, that a third of pregnancies are induced, and most of those will be just for being overdue. So the protocols and policies vary across countries and trusts and practitioners. There are some countries that they have induction at 41 weeks, some at 42 weeks, but some women don't have their babies naturally till they're 43 or 44 weeks. There's not really any hard, fast facts around when is the best time to induce what is deemed to be prolonged pregnancies. But then that's a whole other argument, is what is a prolonged pregnancy? Who deems that it is prolonged? And there's the thing that we must bear in mind is that ultimately the decision is still the woman's to make, whether she accepts induction or not. The CQC service user surveys give us a lot of evidence about the women who are involved in induction. And I'm a huge fan of Dr. Sara Wickham. She is a midwife, but she's a research midwife, and she does all the hard work for you. So if you're doing a dissertation or an essay, I would highly, highly recommend that you explore her website, but very much her books. She has written 2 books now around labour. One was called Inducing Labour, and the other one, which is not, it's only been released a couple of years ago, I think it was called In Your Own Time. And they are looking at the evidence specifically around induction of labour. And her latest book, which has just been released this week, I believe, is on plus size pregnancy, which is a very interesting read. So again, definitely go along to her website and you can get masses of information and current information around the evidence surrounding a whole vast array of topics. I think I've probably got most of the books she's ever written. And I say there's the interpretation of the evidence as well. You can very much find evidence to suit your perspective, but is it really very good evidence? A lot of the evidence we are working on, if you look at a lot of NICE guidance, it's expert opinion, it's not grade A evidence. And as I say, ultimately it is the woman or the birthing person's choice as to whether she accepts induction or not. So it's useful when we're thinking about induction to think about, natural labour anyway, what happens in a natural labour. And so it's often very slow at the beginning. They may have a show. The uterine activity increases, and it's often very wave-like. And that makes you think of people who hypnobirth and the use of language around labour and birth. And often you'll hear hypnobirthing women say they would prefer the name surge to wave. And when you think about it, that's actually a much more realistic description of what is happening in the uterus, because although it is contracting, it is much more wave-like in how it occurs. Sometimes there's spontaneous rupture of membranes. The cervix softens, it becomes more anterior, it effaces, it dilates, and there's a whole cocktail of naturally occurring hormones that occur. And there is a fantastic article by someone called Judith Lothian, who talks about the importance of those last few weeks of pregnancy and early labour, and talks about that's the time when antibodies are passed, there's a nesting urge, it's sort of that preparation for parenthood occurs, and all these cervical changes also happen. So let's look at the methods of induction. So you have stretch and sweep, which a lot of people don't consider as a part of induction, but it is. And synthetic prostaglandins. Then you've got balloon catheters or rods, and artificial rupture of membranes and artificial oxytocin. So stretch and sweep then. In order for a stretch and sweep to be undertaken, it involves a vaginal examination. So it is an invasive procedure with all the risks that are involved with invasive procedures. The most common for the women is discomfort, bleeding. They might get irregular contractions afterwards. So what the midwife is actually doing is putting her fingers in the vagina and sweeping a finger between the membranes and the internal os of the cervix. And it's thought to release prostaglandins and trigger contractions. Now, a Bishop score is a score given to determine the position, consistency, effacement, dilatation, and station of the baby, to determine how effective that might well be. And so the higher the score, the more likely it is that it will be successful. Now, there was a Cochrane review in 2018, which they updated in 2020. Didn't really find any changes in their findings, but the 2018 review concluded that routine use of stretch and sweeps from 38 weeks, which a lot of trusts do, had no clinically important benefits, none at all. But as part of an induction process, it did potentially reduce the need for more formal methods, but that you needed to outweigh the benefits against the discomfort for women and the adverse effects of it. The 2020 update said the findings, they found that 6 out of 10 women went into labour with no stretch and sweep. 7 out of 10 went into labour with a sweep. So literally 1 woman difference. The evidence they suggested that it might be effective in achieving spontaneous labour, but the evidence is of low certainty. So moving on to our synthetic prostaglandin. So very often when a sweep's been unsuccessful, then women are offered to come in for induction of labour, and that induction process very often starts with a synthetic prostaglandin. And synthetic prostaglandins are not going to be, they work specifically on the cervix and the uterus. You're not going to get all those other effects that natural prostaglandins will trigger. So the types of prostaglandin, you've got propes, you've got prostin gel or pessaries, misoprostol, and the dose and type will very much depend on the previous birth experience and the parity of the woman. You often find that women who have got had previous births will very much often have a lower dose than a primip. And also women with previous caesarean sections. Now, there was a time where caesarean section was completely contraindicated for synthetic prostaglandin, but a lot of units now will use it, but they'll use it very cautiously. There is, again, you've got very often with the induction process, you have multiple vaginal examinations. So every time we're doing a vaginal examination, we risk introducing infection, and there are side effects and contraindications. And side effects often will be hyperstimulation, which can lead to fetal heart rate abnormalities, quite painful contractions for the women. It can come on quite hard and fast, and then fizzle out. If you're using prostin gels and pessaries, they're administered, and then usually 6 hours later they'll have a second dose. And historically, certainly I've known, and I'm sure most units are the same, that very often happens for these women is they get to the sort of 6 hours when they're due to be reassessed and a second dose given, but the acuity on labour ward is such, or the staffing is such, that they can't facilitate that. So essentially, by the time they can facilitate the second dose, the effects of the first one pretty much wore off and you're starting again. Propes does, to a great extent, reduce that, because it's a single dose. It's like a little plastic strip that's impregnated with a prostaglandin, and it has looks like a little mini flattened tampon because it has a little string on it, and it sits in the posterior fornix of the cervix and gives a slow release over sort of 24 hours. So that is, you don't have those same risks of high and low levels within the bloodstream. There are contraindications, as I say. If you're thinking about prostaglandins, certainly severe IUGR or any sort of Doppler abnormalities, high presenting parts, any cephalopelvic disproportion or abnormal lies, you certainly wouldn't be in a big hurry. As I say, vasoprevia or any undiagnosed PV bleeding, you should really be extremely cautious and not really use vaginal prostaglandins. Previous caesareans, as I've said, or hysterotomies, cervical tears, if there's pelvic structural abnormalities, if there's active cardiac, pulmonary, renal, hepatic disease, if there's active herpes, cervical cancer, untreated severe raised blood pressure, and we're talking severe here because it may not be appropriate to, in severe blood pressure cases, to do an induction. It may be more appropriate to do an elective caesarean. And then obviously anyone who's got hypersensitivity to the ingredients that are in the prostaglandins used. And before we move on, I realise I didn't mention misoprostol, and that's because misoprostol tends to be used mostly in the termination of pregnancy or induction for intrauterine death. So looking at mechanical methods, so these are methods which will encourage cervical ripening. So that's that making that cervix much more ready for labour. And so there's Foley balloon catheters, which are very, very similar to a Foley's catheter that you would use in the urinary system, except that often the balloon bit where you put the water is much bigger. And they tend to put pressure on the cervix to try and encourage that prostaglandin release. And then the rods, or laminara sticks as they're sometimes known as, they actually absorb the moisture from the cervix, so they expand by absorbing that moisture and again put pressure on the cervix. The most common side effects are bleeding and pain, but then with anything that you're putting into the vagina, be it gloves or gel or anything, you have the potential to disrupt the normal bacteria, the normal balance of the vagina, and also introduce bacteria. So that normal bacterial balance is in there, and you could introduce bacteria, both of which are potentially going to cause infection. So artificial rupture of membrane, so what is it? This is where we break someone's waters. So the membrane, the bag of membranes that surround the baby, protecting it and maintaining temperature and all sorts for the baby there, and cushioning that process. We are essentially doing a vaginal examination and using a piece of equipment called an amni hook, which looks like a very long crochet hook, for want of a better word, with it has a small hook on one end. You need to be really careful when you're using it, because not only can you cause discomfort to the woman if that hook catches a vaginal wall, you can also cause discomfort to yourself if the hook catches your fingers. Depending on how bulging those membranes are can depend on how easy or not that process is. If they're bulging, then very often it's quite easy to do an ARM, because you're sliding the amni hook between your fingers and you're pressing the little hook against the membranes to rupture the membranes. And so if they're bulging, that's a bit like popping a balloon that's filled with water. It's relatively easy to do. If they're tight against the baby's head, that can be much more problematic, and it can take several attempts. Obviously, the more dilated the woman is, the easier that is. It's extremely difficult to do it very often on the cervix that's only 1 or 2 centimeters dilated. Most women will need augmentation after this. Again, the length of time after following an ARM before augmentation is commenced, that sort of Synto drip is commenced, it varies from trust to trust, and it also very often varies depending on whether the woman's a primip or a multip. In my own trust, multips are given 4 hours before they would start Synto, and primips 2 hours. Again, this is down to maternal choice, and you have to have that conversation with her about the pros and cons of all of those. Very often, performing an ARM will ramp up the contractions and that pain quite exponentially. So if she's been having irregular contractions, then suddenly the pressure of that baby's head pressing on the cervix can really increase that pain very, very quickly. From my own experience, I wasn't a midwife when I had my son, but I was a nurse, and he's 40 now. So back in the day, ARM was commonplace, and actually with no conversation with yourself as to whether or not you wanted one. And I remember the following year when I declined, I was very much frowned upon. But it was routine to do an ARM at 3 centimetres back then. And I, as a primate, had got to 5 or 6 quite comfortably, coping very nicely. And then as soon as I was ARM'd, the contractions became unbelievably painful and necessitated me having some pethidine in them, because it was just really, really too difficult to cope with. So you need to be aware that that can have a massive impact on how the woman is coping. And equally, if it's part of the induction process, absolutely nothing can happen, and they will need to have that Synto drip started. Once we've broken those waters, then we have got that risk of ascending infection. So asepsis in anything we are doing, particularly vaginal examinations, is very important. And as I said before, part of the process very often for these women is they're having multiple vaginal examinations. And we really do need to be mindful of both the risks of infection to her and the baby. There's a risk of cord prolapse when you're interfering and doing an ARM. And very often there are CTG or fetal heart abnormalities at point of ARM. They usually do resolve, but you will often get those when you're doing an ARM. So Oxytocin, sorry for the sudden increase in font size. I'm not quite sure what I was doing when I was typing that. So synthetic versus natural. So synthetic for Oxytocin won't cross the blood-brain barrier. So you won't get the same overall effects of Oxytocin that you will with natural Oxytocin. You won't get those feelings of calmness and love and all of those, because it's working specifically on the uterus and the cervix. That's it. It's not working anywhere else. The rate of infusion is variable, not only worldwide, but within this country, within various trusts. There's no consensus of what is an acceptable rate of infusion. And the World Health Organization did actually point out that, Oxytocin is really quite a dangerous drug, and its use, we should be really quite judicious in how we're using it. And I'm not sure we are. We've become very sort of blinkered to the fact that Oxytocin is quite a dangerous drug, and we use it very liberally. There are some trusts who will just ramp it up and then leave it ramped up. There are other trusts who will ramp it up till they get the desired number of contractions, and then if the woman is contracting really nicely, they'll either turn it down or switch it off. As I say, there is no real consensus over what is a safe rate of Oxytocin infusion. There are, as I say, that you have to be quite cautious, and there are some contraindications with Oxytocin. You need to be very mindful if you have anyone that's had any sort of uterine surgery. You'd be very, very cautious, and you'll find a lot of places will use it for VBACs, but they will be extremely cautious. Side effects, like a lot of drugs, obviously there's the side effects of Oxytocin are less so than the ergometrin, when we used to give symptometrin quite a lot for third stage management, but you will still have side effects for some women. There will be nausea and vomiting. It will also, if you've had an Oxytocin infusion for quite some time, it can affect your fluid balance as well. So urine output can be reduced post-delivery. So when we're looking after a woman having an induction of labour, it's clearly, certainly being offered an induction of labour, I should say. It's important that we make sure she has all the information to make that informed choice. And we need to respect her wishes. So the NMC Code of Conduct does say that patients, and it says patients because it's for nurses and midwives, have the right to decline our advice. And we may not like them declining it, but they have the right to decline our advice. And our job is to make sure they've had all the evidence-based information to make that choice. So if she has accepted the induction process and she comes into hospital, then you need to undertake a full antenatal examination. So it's a full set of maternal observations, full abdominal examination, and auscultation of your fetal heart. And then before the process actually starts, very often these women will be having a 30-minute CTG to ascertain fetal well-being before the process starts. As I've said before, we need to maintain asepsis wherever possible, although childbirth is not an aseptic process. She's not in labour yet and she's not delivering yet. So we need to, until that point, we really need to be maintaining asepsis wherever we can, particularly for vaginal examinations and especially if they've got ruptured membranes. And then you've got ongoing monitoring of the woman and the baby. And that will, again, vary from trust to trust. In my own trust, they have 4-hourly CTGs and observations are done every 2 hours. If they are requesting analgesia, then we would probably, even if it's not 4 hours, we would probably restart that CTG and just see what's going on as well. It's really important that we have documented all our discussions with the woman, her wishes for labour, and any care that we have actually delivered. We need to make sure that she is aware of signs and symptoms that she needs to alert us to, that she has a call bell that she can alert us with, that she's aware of the side effects of any medications we might be offering her. And also as well, discuss the birth plan with her. Just because she's having an induction doesn't mean that everything she perhaps wanted for her labour can go out the window. There's a lot of things that you can actually accommodate even for women having inductions of labour. I mean, I've undertaken a pool birth on a gestational diabetic that was having an induction of labour. So there is plenty you can do to actually facilitate as many of her choices as possible. And if you can't facilitate them, then you have that discussion as to why that might be difficult to actually facilitate. So on these last couple of slides, I've just put actual links to some of the evidence that I was talking about throughout the presentation. So hopefully you'll find those quite useful, particularly Dr. Sara Wickham. And there you have it, induction of labour. I hope you found the video useful. If you haven't subscribed to the channel already, please do so. Please share with your friends and find us on Facebook at The Motivational Midwife.